Welcome to the recorded lecture on acid-base analysis by arterial blood gases. The primary objectives of this lecture is to get you competent in thinking of how to apply the knowledge of acid-base physiology in clinical applications of interpreting the arterial blood gases. To be competent in this content, you will need to be proficient in fundamental physiology of gaseous transport in human body. Also, you will need to know the oxygen dissociation curve and normal values of pulse oximetry. I encourage you to review these from physiology, along with any additional self-review materials I have posted on this. This is the summary page. You will notice there are just two content areas, the arterial blood gases and how to evaluate the arterial blood gases. The third one is just cheat sheets that help you achieve your target goals. We start the main section of the presentation here with a discussion on arterial blood gas physiology. When the body is in a critically ill state, the acid-base status, which is usually in balance, can easily get disrupted. It is therefore vitally important for close monitoring of the acid-base status. Acid-base status is determined by drawing arterial blood and getting a computer to analyze the levels of pH, PaCO2, bicarbonate, PaO2, along with base excess and anion gap. This test is called the arterial blood gas report. From these parameters, we are able to decide if the acid-base abnormality is from a respiratory disorder or from a metabolic disorder. It can also be a mixed complex acid-base disorder. The medical and PT treatment is then tailored based on which type of disorder it is. Obviously, metabolic acid-base disorders cannot be treated by PT. It requires medical management, typically in the form of infusing the buffer element to bring the patient into balance. However, for respiratory-linked acid-base abnormality, physical therapy is a very important intervention. The ABG report tells us of these important parameters. Notice the sequence of information laid out below. There is relevance to this sequence. If you look for internet resources, you will notice that sometimes the sequence is different. However, I recommend you to learn to read these reports in the following sequence for reasons that will become evident. Arterial tap is painful and expensive. It requires a special needle with a cutting tip, and the patient can have complications of continued bleeding, or an infection can be introduced into the arterial space. The arterial blood gas reports on two main elements, the acid-base status and the partial pressure of oxygen in the blood, the PaO2. Note that the PaO2 does not directly concern the acid-base status, but rather the state of oxygenation in the body. What are the goals of an ABG analysis? We seek to answer these questions. Is there an acid-base disorder? If so, is it acidosis, alkalosis, or mixed? Is there a need for mechanical ventilation? And whether the ongoing mechanical ventilation is successful. We find that out by evaluating the amount of carbon dioxide in the ABG report. If CO2 is normal level, that means the ventilator is able to drive out the carbon dioxide from the lungs. The report informs us whether the body buffer systems are working. If the body buffers are working, we see evidence of which system is providing the buffer and whether the process has started yet or not. If it has not started, then urgent external interventions become necessary. The arterial blood gas also supports decision-making on long-term oxygen therapy needs in chronic lung disease. Some other terminologies on an ABG report include anion gap and base excess, which I have used previously. Let us look in the later sections what they mean. Recall from physiology that all body fluid compartments must be electrically neutral. That means there has to be as many anions as there are cations. The picture shows you how the sodium is the predominant cation in the extracellular fluid. This is counterbalanced by the anions chloride and bicarbonate. However, chloride and bicarbonate do not add up totally to the amount of sodium. Therefore, it appears as if there is not sufficient anions to counterbalance the cation in the ECF. However, there is actually a very small amount of anions, which are generally proteins, that cannot be directly measured in the ABG report or any other lab value. Hence, they are reported as the gap, the so-called anion gap. Thus, we can define anion gap as the concentration of unmeasured anions in the extracellular fluid. The normal reference range of anion gap is 8 to 16 millimoles per liter. Now this slide shows you the calculation of the anion gap. This is not for you to memorize, but to understand the concept more clearly. It is more important for you to interpret the increase or decrease of the normal anion gap. Now, the major uses of the knowledge of anion gap is to signal the presence of a metabolic acidosis and confirm other findings. It also helps differentiate between causes or sources of a metabolic acidosis. Where in the body is the acid coming from? It also helps to assist in the biochemical severity of the acidosis and follow the response to treatment. This slide shows you from where too much acid can usurp the normal acid-base state of the ECF. So there could be overproduction of fixed acids, for example, lactic acid, or somebody could ingest some acid, or certain pathologic states such as diabetic ketoacidosis. Now, these are all sources of fixed acids that come from metabolic processes. This slide shows the interpretation of the changes in an anion gap. If the anion gap is too large, in other words, a high anion gap, then it signifies metabolic acidosis. See the slide for different conditions when it occurs. A low anion gap is seen rarely, and often it is a lab error. It can occur specifically in conditions, for example, hypoalbuminemia, among others. Under some circumstances, we also see a state of acidosis where there is no anion gap. This is usually seen in case of massive fluid loss, for example, in diarrhea, in renal failure, etc., when there is a loss of extracellular fluid, bicarbonate, and chloride getting retained. The other ABG report parameter that is important to understand is the base excess. The base excess is an indicator of tissue perfusion. As tissue perfusion decreases, the lactic acid that is generated by the tissue is unable to be cleared, causing it to accumulate. This is same as serum lactate, and that is reported as base excess. Now, it is a little weird nomenclature because what we really are looking for is base deficit because it is reported as base excess. It will become apparent to you as we go forward. If there is accumulated lactic acid, that means there will be acidosis. Without adequate base, it cannot be neutralized, causing acid state to pervade. Thus, we are really looking for a deficit of base which leads to acidosis, but it has become convention in calling it base excess. So to clarify further, the base excess is a number indicating the amount of base present in the body that can neutralize the lactic acidosis from the tissues. If there is too much base, it is excess. Otherwise, there is a deficit. Now, the report will always state base excess. The bases are listed, and it is a combination of all these bases which act as buffers. Remember, one last thing. Base excess or deficit reflects the magnitude, that is, how bad is the state of the metabolic disorder. It does not reflect um, the respiratory disorders. So an abnormal base excess report is reflective at least a component of metabolic acidosis or alkalosis. It does not reflect respiratory conditions. The normal range of base excess is -2 to +2. Greater the negative number, the greater is the lack of base, which means patient is more acidic from metabolic causes. So how to analyze the base excess or deficit report? At a -5, the patient is mortally sick. If urgent resuscitation is not done, the patient will die. Resuscitation requires infusing base to bring the patient back to normal pH. However, it is important to remember that the patient may still die from other causes. I've already discussed this. There is a confusion with base excess terminology. This is therefore a visual representation of the confusion of base excess terminology. The confusion stems from the fact that metabolic acidosis is described as negative base excess. Therefore, negative base excess is actually acidosis. More positive amount of base excess is therefore an alkalotic situation. This is the summary page. You will notice there are just two content areas, the arterial blood gases and how to evaluate the arterial blood gases. The third one is just cheat sheets that help you achieve your target goals. Okay, let's look at evaluating the blood gases in this section. We will learn about ABG interpretation from the report. The report never tells you what is wrong with the patient. It just gives you the numbers, and the reader or the clinician makes the clinical interpretation. In days before electronic medical records, this is how the ABG report would be printed. It would appear on a printer paper not much unlike a credit card receipt. It would be transferred onto patient record by hand and interpreted by the clinician. Nowadays, these reports are available on the electronic medical report lab values section or in a designated section that is named differently by various different EMR vendors. In this report, you see how the report sequence shows you pH, PaO2, PaCO2, bicarbonate, and base excess. There can be additional information on these reports. This is just an example. In evaluating the ABG report, one of the first mistakes to not make is to look at numbers in terms of high or low. Instead of that, we look for whether the report indicates normal or acidotic or alkalotic or mixed acid-base disorder. Once we figure that out, we look for whether the patient's body is attempting to or even achieving the homeostatic ability to bring the patient back towards normal pH. This homeostasis is called compensation. To evaluate the arterial blood gas, we look at two overarching components, the acid-base status and the oxygenation status. There are 6 steps to analyzing the acid-base status. It must be done in this sequence. You have been given a cheat sheet to ABG analysis. Retain this cheat sheet. Use it to guide each of the practice ABGs that you will perform. You will use the same cheat sheet to perform your ABG worksheets in class. However, remember that in the final exam, you will have to remember these steps to analyze the ABG reports presented in the exam. I will write several ABGs for you to analyze in the final exams. The first step is to see if the pH is normal. If pH is normal, then the patient is either normal or there may still be an acid-base abnormality, but with compensation. Otherwise, if clearly abnormal, it will indicate whether the patient is acidotic or alkalotic. The next steps allow us to determine if there is a true acid-base abnormality, and if so, whether it is due to respiratory or metabolic processes. So the second step, we look at the PaCO2. Is it normal? Is it acidotic? Or is it alkalotic? In the third step, we look at the bicarbonate, the HCO3 minus. Is it normal? Is it acidotic? Or is it alkalotic? Now you have to determine whether this is a metabolic or respiratory abnormality. To do this, we look at first 3 steps, which is pH, PaCO2, and bicarbonate, and match either the CO2 and the bicarbonate and determine which one of those match the pH. In other words, we are looking for the pair which has the same interpretation. This tells us the primary imbalance that the patient has, either acidotic or alkalotic. Finally, we look at the oxygenation status. Remember, oxygenation does not impact the acid-base status at all. What it tells us simply is if there is adequate oxygen, partial pressure in the blood. It determines need for supplemental oxygen, and supplemental oxygen will fix the hypoxia part of the patient's impairment, but it does not influence abnormal acid-base status. This is the pH scale. Recall the normal pH is a tightly controlled narrow range of between 7.35 to 7.45. Below 7.35 there is acidosis. Above 7.45 there is alkalosis. Step 3 is to look at bicarbonate. Bicarbonate is a base. If it is high, then acid-base status is alkalotic, in which case the patient will be alkalemic, which makes the pH high. If it is low, then the patient is acidemic and the acid-base status is acidotic. Next, we look for whether the body is attempting to compensate. There is a way to figure this out by comparing the PaCO2 with the pH and also the bicarbonate with the pH. In the next 6 slides, we will learn how to figure out compensation. When we compare the pH with carbon dioxide, we look for if the relationship is opposite. If the relationship is opposite, any pH abnormality is due to respiratory cause. This is because if a pH is high and the PaCO2 is low, then the patient is alkalemic due to respiratory causes. This is typically seen in patients who are breathing too much and too fast, as you can see in people with anxiety. Opposite scenario is when the pH is low and the PaCO2 is high. Again, the relationship is opposite. Hence, it proves two things. One, this is a respiratory related problem. And two, it is acidosis due to low pH and high PaCO2. Recall that carbon dioxide is an acid. On the other hand, if pH is abnormal and when comparing it with bicarbonate, if the relationship is equal or it shows that it is headed in the same direction, then the acid-base balance is due to metabolic causes. So to give you an example, if the pH is high and bicarbonate is also high, which means it's headed in the same direction, then the patient is alkalemic. Conversely, a low pH and low bicarbonate heralds an acidemic patient. A good way to remember this step 5 of acid-base analysis from the ABG report is to remember the acronym ROME, which stands for respiratory opposite, metabolic equal. See the cheat sheet below, which was explained in the last 2 slides in a neat grid. Note the opposite relationships for respiratory and equal relationships for metabolic. Now to check for compensation. I have briefly introduced the term compensation before. Let's look at what is compensation. Take a look at the normal pH range below. While the normal range is 7.35 to 7.45, the absolute normal pH is considered at 7.4. Remember that for purpose of evaluating compensation, the body wants to always remain as close to 7.4 as possible. Even within this normal range, therefore, going down from 7.4 towards 7.35 is reflective of sliding towards acidotic territory. Conversely, pH movement towards 7.45 is reflective of sliding towards acidemic territory. While the patient still remains normal, I just wanted to convey the concept of absolute normal 7.4. So, if the pH of a patient is deviating from 7.4, some form of events need to occur to bring the patient back to absolute normal. Let's look at the two organs which perform this balancing act. In this graphic on screen, consider that the pH is held steady at a neutral 7.4. Let's assume that the lungs are, for some reason, unable to continue its job of clearing the blood of the accumulated CO2. That means CO2 is retained and PaCO2 goes up. Consequently, hydrogen ion is also going to go up and the pH will turn lower than 7.4, rendering the patient more acidemic. In this case, the opposing system, the kidney, will ramp up the compensatory effort. It will either retain bicarbonate or manufacture more bicarbonate to raise the base buffer in the blood, which will then absorb the hydrogen ion acid and return the body to neutral pH. Additionally, the kidneys will also excrete hydrogen ion in the urine, thereby reducing the acid load. This scenario would be seen in respiratory disorders where the lung is the culprit. If the opposite scenario happens, metabolic processes would create more acid, and then the lungs would kick in and attempt to get rid of the additional acid in the blood. The lungs react to compensatory need very fast, requiring minutes to hours to kick in. However, the kidneys have a slower reaction lasting hours to days before it fully kicks in. Now, these are your normal ABG ranges. Please pay attention to the sequence in which pH, PaCO2, bicarbonate, and PaO2 has been listed. PaO2 is not part of the acid-base analysis because it does not contribute to acid-base state. Now, notice something interesting. When reviewing lab values in general, look for how tight the ranges are. If a range is quite tight, as you can see the pH is, then even a mild deviation will make the patient symptomatic. Using the pH example, if the patient is 7.3, then the deviation is a mere 500th out of range, yet they can become quite symptomatic. On the other hand, PaCO2 is a wide range of 35 to 45. Given such wide range, a patient who is at 30 PaCO2 is abnormal, but may not be symptomatic. Looking at the left image first, and in summary, here is what happens when the values become abnormal. When the pH is less than 7.35, the patient is acidotic, and when the pH is more than 7.45, the patient is alkalotic. When CO2 is less than 35, patient has alkalosis, and when it is more than 45, then the patient is acidotic. So once again, you can see that the CO2 goes the opposite direction of the pH. This is why we do not talk of the values being high or low, but we talk about the interpretation of the values instead. Looking at the bicarbonate status, if it is less than 22, then it is acidosis. When it is more than 26, it is alkalosis. Recall that the kidney can either restrict the loss of bicarbonate in urine or produce more bicarbonate. Both processes will ensure sufficient availability of the base to neutralize the acids usually produced by the opposite system, the lungs in this case. PaO2 tells us of the dissolved oxygen status. It does not contribute to the pH. Less than 80 is hypoxemic. It indicates the need for supplemental oxygen. Because dissolved oxygen does not contribute to the acid-base status, supplemental oxygen is not a cure for impaired acid-base. PaO2 more than 100 is not feasible unless patient is on supplemental oxygen. If PaO2 goes more than 100, then too much supplemental oxygen is being given, which can become toxic, especially to COPD patients who survive on oxygen drive. Hence, supplemental oxygen will need to be titrated down in these patients. Finally, SaO2 or saturation of oxygen indicates bound oxygen to hemoglobin. Less than 95% is indicative of hypoxemia, again indicating need for supplemental oxygen. Of course, saturation of oxygen can never be above 100%. The image on the right reinforces all this analysis in a different graphical format. Finding acidosis or alkalosis. If pH is more, it is acidosis. If pH is less, it is alkalosis. The next is to find compensated, partially compensated, or uncompensated ABG problem. When CO2 is high, but pH is normal, instead of being acidic, then bicarbonate levels are also increased. Then it means that the compensatory mechanism has retained more bicarbonate or produced extra bicarbonate to maintain the pH. When PaCO2 and bicarbonate values are high, but the pH is acidic, then it indicates partial compensation. It means that the compensatory mechanism tried but failed to bring the pH to normal. If pH is abnormal, and if the value of either PaCO2 or bicarbonate is abnormal, it indicates that the system is uncompensated. This is probably because of either respiratory or metabolic acidosis. Let's now do a practice ABG analysis. See this case below. It only records three things: pH, PCO2, and bicarbonate. So based on the results that have been offered, we have to decide, is it an acidosis or an alkalosis? The pH here is listed as 7.5. This is higher than normal, so we have an alkalosis. The next question to answer is the problem respiratory or metabolic in nature. Where else is there an alkalosis? So if you look at the bicarbonate, it is 32, which is higher than its normal 26. So we have a metabolic alkalosis. Next thing is there any compensation occurring? Has the body tried to fix the problem? We need to look at other component in this case, which is the CO2. The CO2 is the opposing element and is outside its normal range, which is 47 in this case, and 47 is higher than the upper limit of PaCO2, which is 45. So the body is trying to fix the problem. However, the pH is not yet back within normal range, so we can state that a partial compensation is occurring. Therefore, this ABG is an example of a partially compensated metabolic alkalosis. So let's recap. 1. Is it an acidosis or an alkalosis? What is the pH? Is there an acidosis? Yes, if it is less than 7.35, or no for an alkalosis, because alkalosis would require a pH of more than 7.45. Second question, is the problem respiratory or metabolic in nature? So look for the match. If the CO2 matches the altered pH, the problem is associated with the respiratory system. If the bicarbonate corresponds with the altered pH, then the problem is metabolic in nature. And finally, is there any compensation occurring? Has the body tried to fix the problem? Has the other component, opposite to where the problem lies, gone outside of its reference range, and to what effect? Has the body done a good job of fixing the problem? So remember that compensated equals the pH is close to within normal range. That is, the body has used its buffer system to normalize the pH. And uncompensated would mean that the pH is outside of its normal range, where the body's buffer system is yet to or has failed to bring the pH back to within normal range. Let's do another practice arterial blood gas analysis. On the screen, there are three values that matter to the ABG analysis: the pH, the PaCO2, and the bicarbonate. The questions to answer begin with, number 1, is it an acidosis or an alkalosis? To answer that, we can see the pH, and it is 7.30. This is lower than normal range, so we can say that there is an acidosis. The second question is the problem respiratory or metabolic in nature? So what else is acidotic other than the pH? If we answer that, we can answer this question of if the problem is respiratory or metabolic. If you look at the carbon dioxide, it is 50 and it is very high. So we can say that the PaCO2 is responsible for the pH being low, because PaCO2 is a respiratory impairment because the lungs are not able to deliver on getting rid of the carbon dioxide, which is the acid. So it is respiratory acidosis. The next thing to look at is there any compensation occurring? Has the body tried to fix the problem? So we need to look at the other component, which is the bicarbonate in this case. Is the bicarbonate outside its normal range? So yes, the bicarbonate is outside the normal range, because the normal range is 22 to 26 and the bicarbonate here is 30. So the body is trying to fix this problem by raising the bicarbonate level. How is it doing that? It is probably either manufacturing more bicarbonate at the kidney level, or it is retaining bicarbonate from being excreted in the urine. So has the body done a good job at fixing the problem? Well, to answer that, you have to again look back at the pH. Is the pH back within normal range? And the answer is no. The pH is not within normal range. So, considering that the body is doing something about it, it may be failing, but it is doing something. Therefore, this is a partial compensation occurring in the body. So this ABG is therefore an example of a partially compensated respiratory acidosis. In this last one, you can do this practice arterial blood gas analysis by yourself. So you see the values provided for the three critical elements for analyzing an acid-base status, and you can use your cheat sheet or the previous examples for arriving at an answer. In the ABG worksheet, this is exactly what you would have to do. You would have to look at the pH, the PCO2, and the bicarbonate. Remember that oxygen is an independent evaluation that does not impact the acid-base status directly. These are variations of arterial blood gases in the acceptable and not so acceptable territory. Taking the first example here, this pH at 7.0, you can tell that it is very low. That is much lower than the lower limit of what is normal at 7.35. Looking at PaCO2 right here, it is significantly high, that much higher than the normal range of 35 to 45. Hence, this is severe acidosis due to respiratory disorder. As you can compare, low pH, high acid from the PaCO2, therefore it is related, and that is a respiratory disorder. The opposing system of bicarbonate is greatly reduced, signifying that the body is compensating. That is why bicarbonate is used up. However, despite the compensation measures of the body, the pH remains still acidic, actually significantly acidic. Hence, it is the final analysis of a severe respiratory acidosis with partial compensation. You can try the other ones for practice. One thing to keep in mind is that the information in the green box at the bottom, we do look at how bad the acid-base impairment is. This acid-base status, which we obtain on a report, is a snapshot in time. However, it is important to look at how quickly the patient's arterial blood gas is deteriorating. A faster deterioration that lasts minutes to hours is significantly worse than a deterioration that lasts over several weeks to months. Finally, we look at the oxygenation status. The PaO2, or the partial pressure of oxygen, is reported on the arterial blood gas. It tells us what is the oxygen reserve, which is the dissolved gas in the bloodstream. Recall that the dissolved gas serves as the reservoir of gas from which the hemoglobin replenishes itself. Imagine a hemoglobin molecule traveling down from the heart, dispensing its oxygen molecules to the tissues along the way. It will be a complete cycle before it returns to the lungs for reoxygenation. Along the way, once the hemoglobin molecule has delivered all its bound oxygen, it will replenish itself from the dissolved gas within the bloodstream. So, the PaO2 status reflected on the ABG report tells us about the amount of dissolved oxygen. Recall again that this dissolved oxygen does not contribute directly to the acid-base status. In other words, it does not impact the pH. So why do we need this? We need the status of the PaO2 to determine the need for supplemental oxygen to be given to the patient. This is the summary page. You will notice there are just two content areas, the arterial blood gases and how to evaluate the arterial blood gases. The third one is just cheat sheets that help you achieve your target goals. This section is full of cheat sheets for your use. The cheat sheets explain how to analyze the arterial blood gas report and figure out the acid-base status of the patient. You can use any of these for the ABG checkoffs. You just can't use it for the final exams. This is the summary page. You will notice there are just two content areas, the arterial blood gases and how to evaluate the arterial blood gases. The third one is just cheat sheets that help you achieve your target goals. This is the summary page. You will notice there are just two content areas, the arterial blood gases and how to evaluate the arterial blood gases. The third one is just cheat sheets that help you achieve your target goals.